Hello, everyone, and welcome to the MANNA Institute academic seminar today on cancer and malnutrition. Our agenda today will be introductions. I am Julian Henstenberg, Director of the MANNA Institute, and I will be moderator for today. I will make all the introductions, talk about a few minutes about the MANNA Institute. We will have our seminar presentation, and then we will have time for questions and answers. Please submit your questions to the Q&A tab so that we can share them with everybody and so that everybody can see them in that session. Thank you. The MANNA Institute is a division of MANNA where we perform research and evaluation of our medically tailored meal programming. We also educate other healthcare professionals about our model, and we share best practices as well as the results of our research and evaluation. Our goal is to integrate medically tailored meals for anyone who needs them and for those who they are appropriate for their diagnosis and nutritional status. We are presenting this seminar in partnership with Malnutrition Awareness Week, which is always the beginning of October each year. That is put on by the American Society for Parenteral and Enteral Nutrition. And I hope you all enjoyed their seminar series last week, which we were a co-sponsor of. We'd like to take a second and do an audience poll to see who's joined us today. So if you could take a minute and tell us who you are. Thank you, from the standpoint of a health professional. Thank you. Great, thank you very much. Looks like we have a wide range of health professionals with us today. I see a large proportion of registered dietitians, as well as other healthcare providers and nonprofit members of nonprofit community-based organizations. I also see a good amount of students, which is wonderful. Okay, so now I'm so pleased to introduce our speakers for today. Our first speaker is Kara Stromberg. She is a registered dietitian, as well as a clinical manager of nutrition and food services in Temple University Health System, both at Fox Chase Cancer Center and Temple University Hospital Jeans campus. She received her master's degree and did her dietetic internship at New York University. She's a certified diabetes educator, and she also received the 2017 Young Dietitian of the Year Award from the Connecticut Academy of Nutrition and Dietetics. So those of us who are in the field of nutrition and dietetics know what an honor that is. I'd also like to introduce Dr. Rishi Jain. He is a physician and assistant professor with the Department of Hematology Oncology at Fox Chase Cancer Center in Philadelphia. I'd also like to say that he does have a master's degree in human nutrition from Columbia University in New York, and he is a diplomat of the American Board of Obesity Medicine. He's also board certified in medical oncology and board certified in internal medicine. Welcome to our speakers today, and we will begin our presentation.
Good morning. Can everybody see my screen?
Yeah.
Great. So thank you, Julianne, and everyone from MANNA, your team, for having Dr. Jain and me today. We are very excited to be here to share just a little bit of what we do every day at Fox Chase and to share some really exciting stuff. So just a quick overview about what I'll be sharing with you today. We will be talking mostly about malnutrition, specifically in the oncology population. We'll be talking about diagnosing malnutrition, adequate documentation of malnutrition, and then we'll also be talking about a tool that we are piloting here at Fox Chase called Nutrascore. We'll talk briefly about some nutrition guidelines, and then of course, my favorite part, the role of the registered dietitian in all of this work. So let's get started. So malnutrition. Malnutrition at its core is really any nutritional imbalance. We talk about lack of calories, protein, but really it's any nutrients needed for tissue maintenance and repair. This is really important to consider because everybody is at risk of malnutrition, regardless of your starting weight. In the hospital, it's one of those things I think as registered dietitians that we've had to overcome when we like to share our findings that a patient is malnourished, when on the outside, they do not look malnourished at all. But this is something that's very important to remember in clinical practice, that even those who are overweight, so those are the BMI greater than 25, or obesity, so those are the BMI greater than 30, are at risk of malnutrition. This could be due to surgery, disease, or poor diet quality. And that's the one at the end, I think, that really is the trickiest to identify. A lot of my work before coming back into the inpatient setting was done at a large nonprofit primary care agency where we served a lot of high risk, underserved communities. And a lot of the patients that were sent to me on the outside looked overweight or obese. And they were likely sent to me with some chronic condition or just to help them lose weight. But upon further review, a lot of my findings were consistent with some form of malnutrition. And a lot of the providers are really surprised to hear that. So something to always consider as we're working. When we talk about malnutrition in oncology, it's important to understand that this happens a lot. Estimates of incidence of malnutrition in the adult oncology population are between 40 and 80%. Let that sink in for a second. I know it's a really large range, but we're talking that research has indicated that up to 80% of adult oncology patients can become or are malnourished, 80%. That's really, really high. And that really lends itself to the work that we're doing. This can be caused by response to the tumor or cancer treatments. This could be from emotional and psychological changes. That's again, something that we always want to make sure that we're considering. It can be from food aversions, altered tastes. Maybe this is because of chemotherapy or radiation. It can be because of pain or discomfort, thrush, mucositis, sores during food consumption that makes the eating experience unpleasant or painful. This could be also because of weight loss prior to diagnosis. So 40% of patients experience weight loss prior to diagnosis. This could be from anorexia, or like I said, any of these other taste changes or abnormalities. Weight loss of 6% predicts a reduced response to treatment, survival, and reduced quality of life. So poor nutrition status in the adult oncology patients can increase mortality, it can increase length of stay in the hospital, it can decrease quality of life, it can decrease tolerance to radiation treatment, it can decrease tolerance to chemotherapy, and unfortunately, it can decrease overall prognosis. So some causes of malnutrition, if we just look at this graph, again, so we have altered nutrient processing. So if someone is hypermetabolic or hypercatabolic or has any sort of malabsorption or liver dysfunction, we can see altered nutrient processing. Malnutrition can be caused by just inadequate diet. So poor diet, poor appetite, pain, nausea, dysphagia, depression, excess losses, vomiting, ongoing diarrhea, surgical drains, fistulas, and again, malabsorption could also be a cause of malnutrition. This is an etiological-based diagnostic tool that we've seen often in the nutrition world. It helps to identify if someone is at risk for malnutrition. But really the main thing to think about with malnutrition is that it's a continuum, right? Malnutrition can be on any part of this spectrum. We could have non-severe or mild malnutrition, and then it can extend itself all the way to severe malnutrition. And then I just listed some of these things here that we already talked about. So this is just a graphic of some of the effects of malnutrition, but the key takeaway from this is that it really impacts our whole bodies and our whole systems. If we're not getting the nutrients, the calories, the protein that our bodies need, it affects everything we do, and it affects how our bodies process. Diagnosing malnutrition is something that I think we've seen kind of change over the years. I think people who have been practicing clinically for many decades would tell you that they always used albumin and prealbumin to identify malnutrition. At the time, it was something that people were really excited about because it was a clinical lab value that we could test for and we could identify and then say, okay, we have our answer, this patient is malnourished, and they could move on. But malnutrition has really demonstrated that it's much more complicated than that. And now we are seeing that albumin and prealbumin are not primary diagnostic indicators for adult malnutrition. Studies showed that there was that prealbumin and albumin do not consistently change with weight loss, calorie restriction, or nitrogen balance, do not typically respond to nutrition interventions in the setting of active inflammatory response, and that albumin and prealbumin can better reflect the severity of inflammatory response more than poor nutrition status. Okay, so how are we diagnosing for malnutrition then? So the first thing, especially as dietitians, that we do is we look to see if there's insufficient energy intake, weight loss, loss of muscle mass, loss of fat, localized or generalized fluid accumulation. This can be difficult and it may mask weight loss or weight gain. Diminished functional status measured by hand grip strength. Again, this is difficult to do just because we don't always know the patient's baseline. 2 or more of this criteria are required to diagnose malnutrition. Okay, so let's take a look at this chart. These are the clinical characteristics used to identify malnutrition. So the first thing is we've broken this down into acute and chronic and social environmental stages. For acute illness or injury, anyone who's consumed less than 75% of their EER for more than 7 days, or less than 50% of their EER for greater than or equal to 5 days. And again, it would be in moderate or severe. And we can see sort of amongst this chart how this is broken down. Remember, we're looking for 2 criteria to diagnose malnutrition. We also see in weight loss, if a patient has experienced 1 to 2% of weight loss in about 7 days, all the way up to 7.5% in about 3 months, that would be moderate, and then greater than 2% in a week, greater than 5% in a month, Greater than 7.5% in 3 months would be severe, again for acute, and we can sort of follow this chart to identify the criteria used for malnutrition. These are the physical characteristics that we might be able to use. And again, we're looking at mild to moderate, moderate to severe, or severe. This is where we're identifying if body fat has declined. So around the orbitals, the triceps, the ribs, if we've identified muscle wasting, again, used to identify fluid accumulation and reduced grip strength. So when we talk about diagnosing malnutrition, there's a lot that goes into it. And it's really important as clinicians that we look at all these different facets to make sure that we're really identifying malnutrition at its core and then documenting it appropriately. So when we use the nutrition care process, we are assessing food and nutrition history, clinical lab values, tests, procedures that have been done, anthropometric data, so weight, height, BMI, client history. This is where the client tells us kind of what's going on. But a key one here for malnutrition is the nutrition-focused physical findings, or the nutrition-focused physical assessment. So this is an assessment performed by the registered dietitian to determine if malnutrition is present. This is where you're looking at the skin, nail, hair, oral cavity, making sure that you're assessing muscle mass and fat stores. Is there a presence of a pressure injury or a wound? Assessment of fluid accumulation. And just to go back to this slide for one more minute. So again, this is something that we're seeing newer dietitians come out of internships understanding. But this is something that's very important for all dietitians, especially those in the clinical setting, to get trained in nutrition-focused physical assessment. To start to feel comfortable really evaluating the patient, to be trained to comfortably use your hands as ways to assess and identify malnutrition, and to also help create a better identifier for malnutrition when it's present. So another way that we can diagnose malnutrition is through GLIM. This is the Global Leadership Initiative on Malnutrition. This is a newer approach. It's a standardized approach to diagnose adult malnutrition, and it includes 5 indicators to be used in regular clinical practice. There's phenotypic criteria, unintended weight loss, low BMI according to age and ethnicity. So BMI less than 18.5 is something that we were using with Aspen, or BMI less than or equal to 22 if you're greater than or equal to age 70. This phenotypic criteria also takes into account ethnicity when necessary. We're also looking here for reduced muscle mass. Etiologic criteria, this would be reduced food intake, inflammation or disease burden. So for example, acute would be infections, burns, large-scale trauma, closed head injuries. Chronic might be malignant disease, such as cancer, COPD, pulmonary disease, CHF or CKD. And then clinical labs, such as the C-reactive protein, albumin, or prealbumin. Again, albumin and prealbumin here are used to identify inflammation. So one of the most important things for us as dietitians is to make sure that we're documenting our findings adequately. This is going to require a standardized clinical nutrition pathway. So we start with our nutrition screening. Then we perform a nutrition assessment. During that nutrition assessment, we identify that there's malnutrition. We want to make sure that the malnutrition diagnosis is documented. That should include the severity, so mild, moderate, or severe, acute or chronic, or social environmental. Then we also want to document our malnutrition adequately and then ensure that we're having appropriate billing. So when it comes to documentation, it's really important for the dietitian to ensure that the documentation is organized, to make sure that it's easy to locate the diagnosis with severity and the criteria that you selected, to make sure the documentation is concise and that there's an intervention list with recommendations. This is where maybe you would recommend nutrition support, oral nutrition supplements, specific diets, etc. It's also important to have the source of your data, the time and the audience if any counseling was performed. So if you performed the counseling to the patient, you want that documented. If the patient's family was there, you'd like to have that documented. To make sure that there's a clear outlined plan for monitoring and follow-up. And then make sure you're considering the placement of the most important information. Documentation is also really important for the provider when it comes to appropriately billing and coding for malnutrition. For the provider, the document should be precise and complete. The diagnosis and criteria met and clearly stated in the assessment and care plan. This is really important because only a provider diagnosis can qualify for reimbursement. It should include the severity, the clinical context, how it's relevant to the patient's care, treatment provided, regardless of who ordered it. So a lot of dietitians have ordering privileges, especially in the hospital. And so the dietitian may have ordered certain supplements that still needs to be in the physician's documentation. It needs to include monitoring and follow-up, and it also needs to include a discharge summary. So one of the really exciting things that we're doing at Fox Chase to identify incidents of malnutrition in the outpatient population, outpatient oncology population, is we're using something called Nutrascore. Nutrascore is a validated tool that has been found to be novel, fast, and a valid nutritional screening tool for outpatients with cancer. Its simplicity and high level of accuracy in detecting nutritional risk facilitates its applicability. It's recommended for this to be used at all visits if patients are at high risk. And then a score on the Nutrascore greater than 5 identifies patients at high risk and recommends that the patient should be referred to the registered dietitian. So currently at Fox Chase, we are piloting this in 3 physician clinics. We have built this into our electronic medical record, and we are continuing to review data to determine if this is something that we would like to roll out to all providers. So let's take a closer look at Nutrascore. Nutrascore asks a handful of questions, and based on the score, a BPA pops up in the electronic health record to recommend that this patient be sent to the registered dietitian. The questions that we look to have answered here are, have you lost weight involuntarily in the last 3 months? And you can see based on the patient's answer, a score is generated. If yes, how much weight have you lost? And you can see the same happens here. Have you been eating poorly in the last week because of a decreased appetite? And then a thing that's really novel about this assessment tool is it creates nutritional risk and score based on the location of the neoplasm. And you can see how this is broken down here. It continues here. This also assigns a score for treatment. So if the patient is receiving chemo and radiation, if the patient is receiving just chemo or just radiation, and all of this generates a score. Anything greater than 5 would make the patient at risk of being malnourished or at risk of becoming malnourished, and there would be hopefully a referral made to the registered dietitian. So some guidelines that came out specific for cancer cachexia from the ASCO reviewed a bunch of literature to identify when it was appropriate for these certain nutrition interventions. So for dietary counseling, the strength of the recommendation was moderate in favor. For parenteral or enteral nutrition, it was moderate against. For use of omega-3 fatty acids, there was no recommendation. And then for certain vitamins, minerals, and other dietary supplements, again, no recommendation. The recommendations that came from this, though, were that clinicians can refer patients with advanced cancer and loss of appetite and or body weight to a registered dietitian for assessment and counseling. This is really important because even with patients with advanced cancer, there's a lot of things that they cannot control, but one of the things that maybe they can control is how they're eating, how much they're eating, when they're eating, and the dietitian might help be there to empower the patient to encourage them to eat better or to get improved nutrition through their PO. So again, goals might be for practical and safe advice for feeding, education regarding high calorie or nutrient dense foods. An important one would be advice against fad diets and other unproven or extreme diets. Clinicians should not routinely offer enteral or parenteral nutrition to manage cachexia. Again, this is from these guidelines in patients with advanced cancer. A short-term trial of TPN may be offered to a very select group of patients. But again, this is something that we wouldn't want to be recommending often. And then discontinuation of previously initiated nutrition support near the end of life would also be appropriate. So where is the dietitian? I know I've brought up the dietitian a lot in this conversation, but the role of the dietitian is really, really important, especially when it comes to medical nutrition therapy, which is what the dietitian is trained to provide. Early intervention from an RD has been shown to increase quality of life, increase weight, lean body mass, or weight maintenance, increase treatment tolerance, and increase appetite. It's been shown to decrease length of hospital stay, treatment toxicities, and decrease hospital admissions. So here's a chart just to identify some medical nutrition therapy specific to certain cancers and how much energy, calories per kilogram, and proteins will be recommended. This is really important because the baseline for most oncology patients would be 25 to 30 calories per kilogram. But this is just a quick table to kind of better show or illustrate how different types of cancers warrant different medical nutrition therapy. The dietitian should aim to reduce nutrition impact symptoms. So these would be barriers to PO. And again, this is provided with ongoing medical nutrition therapy. For example, anorexia. So anorexia is the second most common in those with advanced cancer. Second, really only to fatigue. Here we're talking about loss of appetite or the desire to eat. Treatment for this or medical nutrition therapy for this would be to determine the cause. So why is someone struggling to eat? And then recommending energy dense foods and beverages, making every bite and every sip count, and then creating a regimen for the patient so that we can really make sure that we're meeting the patient where they're at. Constipation. Constipation can be caused by dehydration, medications, decrease in physical activity, especially if the patient is suffering from fatigue. And again, treatment for this might be a bowel regimen, diet, or increased fluids. And again, this would come from the dietitian in the medical nutrition therapy that the dietitian is providing. Another one here would be mucositis. We'd want to make sure we're encouraging good oral hygiene, magic mouthwash when necessary. Mucositis normally resolves within 2 to 3 weeks after chemo ends. And then for radiation induced, can last about 4 to 6 weeks after treatment ends, depending on the amount of radiation. But again, this is where the dietitian can really get involved to speak with the patient and their family, identify what's going on, and then make recommendations to improve PO. Some of the other nutrition impact symptoms: diarrhea, neutropenia, taste alterations, xerostomia or dry mouth, pancreatic insufficiency, and nausea and vomiting. Okay. So a couple things on behalf of dietitians. If you're not trained in nutrition-focused physical assessment, get trained. There are lots of excellent programs out there. If you didn't have that hands-on practicum or hands-on experience in your internship, this is a great way to get more involved and to become more engaged with your patients and to be able to better diagnose malnutrition. And then, of course, to spread the word to other dietitians about trainings that you really enjoyed. Maintaining ongoing communication with providers regarding patients you share. So when you identify a patient who's malnourished and you've put a treatment in place, you've recommended supplements or you've recommended a certain diet, communicate that with the provider who's covering this patient. A lot of times the providers are really focused on other things, and it's our jobs as dietitian to bring that to the forefront of their minds. This will also ensure that malnutrition is appropriately documented in the provider's note. Also understanding as a dietitian that you are likely the first person to identify that the malnutrition is present. This is because if a patient doesn't appear visibly wasted or malnourished, a lot of time this would be overlooked, and it's our job to really do the diligent assessment to meet that criteria so that we can identify malnutrition. Partnering with billing and coding departments is really important. You can make yourself available to answer questions, and also considering doing an in-service. So a couple extra things about the role of the dietitian. At the end of the day, we are always there to work with the patient, to meet them where they are, to establish a rapport, to provide support and empathy. to empower the patient to do something for themselves that maybe they're not able to do elsewhere in their treatment. We want to make sure to consider cultures, religious beliefs, and family traditions, and then try to work that into our treatment plans and our medical nutrition therapy. We want to be budget friendly. We want to help patients set realistic goals and set realistic expectations when it comes to their nutrition. If they've lost a lot of weight and they're struggling to eat, we can't tell them to go out to dinner and have some huge pasta dinner and think that they're going to tolerate that. We have to make sure that we're setting realistic goals. Maybe that same dinner, their goal is to just take 5 bites of that pasta, and that would be something that they can achieve. That would be something that would be realistic. We want to make sure we're using appropriate literacy assessment tools, recognizing that change is hard. It doesn't matter where you are in your treatment. It doesn't matter where you are on your path to change. Change is hard. And when there's other things such as cancer going on, change can be even harder. So we want to make sure that we're recognizing that and then recognizing barriers. We want to treat each patient as an individual. We want to counsel the patient, not the disease. We want to be creative, inspiring, and we don't want to stop trying. We are part of this treatment team, and we want to make sure that the patient understands that we are there for them. And with that, I'm going to turn it over to Dr. Jain, who is going to continue our conversation.
Thanks, Kara. Share my screen. Can everyone see my slides okay?
Yes.
Okay, great. So hi everyone, my name is Rishi Jain. I'm a GI medical oncologist at Fox Chase, and I have a special interest in nutrition from a more research perspective. So I think hopefully my slides will kind of complement what Kara has, kind of the background Kara has given us. So I do have some disclosures regarding clinical trials that I get funding for. So I'm going to kind of split my talk up into 3 parts. I know we usually think of malnutrition as more undernutrition, and that's kind of been the focus so far, but I am going to quickly kind of highlight where overnutrition and obesity play a role in GI cancers, the cancers that I treat. And then I'm going to switch to the undernutrition side and also kind of touch on some other factors that are related to undernutrition, like sarcopenia and cancer cachexia, and how those impact GI cancers. And then I'm going to wrap up by introducing our recently funded MANNA study in colorectal cancer. So, as I'm sure many of you are aware, obesity is a risk factor for at least a dozen cancers. And most of the GI cancers are actually associated with obesity. So as you'll see, esophagus, liver, gallbladder, stomach, pancreas, and colorectal cancers are all associated with being overweight or obese. And even after the diagnosis, for many of these cancers, being obese is actually a poor prognostic marker. So for some reason, patients who are obese oftentimes do worse, and that could be because of a variety of things. Much is unknown with regards to why they have a worse prognosis, but some suspect it could be because they have more aggressive tumor biology, or perhaps comorbidities prevent certain therapies. But it is a big issue for many of our patients. We're learning a lot about why obesity and related factors actually lead to increased cancer risk. And this is a slide looking at the main hallmarks of cancer. And it kind of highlights that obesity and related factors like hyperinsulinemia or inflammation can actually lead to different pathways which lead to tumorigenesis, like increasing proliferative signaling, increasing the likelihood of invasion and metastasis. So we're learning a lot about why obesity impacts cancer, and it's definitely an important area of research. we oftentimes link obesity to certain circulating substances and alterations in those substances. So, if we have excess inflamed adipose tissue or visceral adiposity, primarily we can see increases in insulin, IGF-1, dyslipidemia. We can also see alterations in pro-inflammatory factors, so decreased adiponectin, increased leptin, and also changes in some of the adipose tissues that support tumor cells. And ultimately, those changes in our physiology from obesity can lead to increased cancer risk via decreased cancer cell apoptosis or increased cancer cell growth, angiogenesis, et cetera. So we really have learned a lot about different biomarkers that are potentially the link between obesity and increased cancer risk. Now, as a GI oncologist, the most common GI cancer is colorectal cancer, and it's the one that I've done most of my work in. So just to kind of hone in on colorectal cancer a little bit. So colorectal cancer is the third most common cancer, and it is the fourth leading cause of cancer mortality. So it is a big public health issue in terms of finding better ways to treat colorectal cancer. Now, I'm sure many of you are familiar with the American Institute of Cancer Research, and that's the leading organization in the United States, which summarizes evidence on the relationships between different lifestyle factors and cancer risk. So these are some excerpts from some of their publications, and as you can see, they've estimated that almost 47% of colorectal cancers could actually be prevented with healthy lifestyle habits, including staying a healthy weight, moving more, eating fiber-rich foods, limiting red meat and processed meats, and trying to avoid alcohol. And then in every few years, they do a continuous update project where they summarize the evidence for different cancers and lifestyle factors. So they gave strong evidence for physical activity, whole grains, eating foods with fiber, dairy, and calcium supplements in terms of decreasing risk. And then in terms of factors that increase risk, they gave strong evidence to consumption of processed meats, alcohol, being obese, being tall, which you can't change, but and then also consuming red meat. So for colorectal cancer specifically, I would say it's one of the strongest cancers that's closely tied with factors like diet and lifestyle. Now, why are these two things related? Well, I think a lot of it is related to the direct interaction our colon epithelial cells have with the byproducts of a lot of the things we consume. So in this figure from a publication, they kind of showed that dietary patterns are really important. So a diet pattern, which is higher in red meats, processed meats, and animal fats, can lead to kind of an imbalance of bad substances in the colon, like bile acids, ammonia, phenols, and other substances, which can ultimately lead to inflammation and have some carcinogenic effects. Whereas a diet pattern that is heavier in whole grains, fruits, vegetables can lead to a better balance with more short chain fatty acid, vitamins, antioxidants, and those types of things can actually have anti-inflammatory and anti-cancer effects. So you'll see dietary patterns becoming a very common theme in the diet and cancer literature, and trying to find that right balance between good things and bad things is really important. So along this line, I got funding to do a study looking at the use of a computerized food frequency questionnaire, which I'll show you about. to improve diet quality in patients who have finished their curative intent treatment for colorectal cancer and are undergoing surveillance, or basically getting periodic blood work and CAT scans for 5 years after completing treatment to assess for cancer recurrence. And this study was done in collaboration with some of my mentors and collaborators at Fox Chase. We also got funding from the American Cancer Society. And I did attend this workshop called TREK. If you're interested, you can look it up. It's based out of Yale, but they are, it's a community that is kind of focusing on energetics research, which kind of encompasses these types of issues. So just to kind of show you what a computerized food frequency questionnaire is. So there is a company called VioScreen. All right, I think the company is called VioCare. Their food frequency questionnaire is called VioScreen. It's basically a validated computer-based FFQ, and it's picture-based. So it takes you through a chain of questioning that takes about 30 minutes, and based on kind of how you respond, it initially asks you if you consume certain foods, and if you do, then it asks you how often you consume the foods, and then it also gives you pictures of different portion sizes to help you estimate how much of that food item you're consuming. And some of the selling points, I think, are that by being picture-based, it might help with recall, and by having some of the portion sizes, again, it might help with improvements in accuracy. I know paper-based questionnaires have been used for many years, but they can be a little cumbersome and they have certain challenges. So we partnered with this company for a variety of projects that we've been using this food frequency questionnaire, and patients have generally liked it. The other aspect of the FFQ was that they designed an automated dietary feedback component. So after you complete the FFQ, it gives you a report of your HEI score, your healthy eating index score, which is based off the dietary guidelines for America. And it subdivides your HEI score into different categories. And then based on your score, it actually gives you specific ways you could potentially improve your score in that category. So for example, this, example, someone's scored pretty low in vegetables. So it kind of gives you options to increase green salad consumption. The person was currently only eating it twice a week. So if you increased it to 5 to 6 times per week, that would have a 0.7 point improvement in your HEI score. So what's nice is it's kind of like a automated intervention essentially. And that was the primary aspect of the intervention. So just to show you the study design, so this was for patients with stage 1 through 3 colorectal cancer who were going through cancer surveillance. Patients would do the baseline assessments, and then a health educator would call them every 3 weeks to see if they were able to follow some of those recommendations given by the food frequency questionnaire. And then the ultimate goal was to improve diet quality by 5 points after this 3-month intervention. So the 3-month assessments are still ongoing, so we haven't analyzed that data yet, but we do have some of the baseline data that we've submitted for presentation. And out of the 20 patients that have completed it so far, the average HEI score was 66. In the United States, the average HEI score is around 59. So it's slightly above that. But as you can see, in certain categories, patients really aren't doing that well. So there's pretty low scores in like whole grains, fatty acids, saturated fats. So there are definitely in sodium. So there are definitely areas that are shown to be weak in this population based on this small cohort. And then we've also kind of looked at some of the baseline factors, and we found that patients who are younger tend to have worse diet patterns. Patients who are obese tend to have worse diet patterns. Interestingly, patients who were married ate worse than patients who are not married. And then the farther out you are from your diagnosis, the worse diet quality got. So this is a small cohort, but it's some interesting preliminary data which helped us kind of design the MANNA study as well. So now I'm going to switch gears, and I know we need to save some time for Q&A, so I'll move pretty quickly. But you know, kind of switching to the other end of the spectrum, the malnutrition end of the spectrum, I think, you know, we've heard from Kara about how to define malnutrition and cancer cachexia, and then sarcopenia, I'm sure you guys are aware, is low muscle mass or function. And it's a busy slide with a lot of definitions, but I think it's just important for us to recognize that a lot of these conditions have a lot of overlapping features. So someone could be malnourished and cachectic, or just malnourished without cachexia. But sometimes we use these terms kind of interchangeably. And I think that's largely because sometimes if we just use weight loss, then that can kind of mean malnutrition or cachexia. So it's important just to know that they are technically different, but there's a lot of overlapping features. GI cancers in particular have really high risks of malnutrition. As you can see, pancreas cancer, there's around a 60 to 70% risk of malnutrition and cachexia. Close to that is gastroesophageal cancer. So these are really tumors that should, you know, integrate nutritional support from initial diagnosis. The cachexia world has kind of taken off, and now there's, you know, cancer cachexia societies, which I'm part of. And in the cachexia community, they found very specific pathways and cytokines that are implicated in cachexia. So our hope is that moving forward, we can identify patients earlier on by using some of these markers kind of beyond weight loss to intervene even earlier. I think the reason this matters, which Kara kind of got into, is that, you know, malnutrition, sarcopenia, and cachexia are ultimately associated with worse cancer outcomes. So decreased tolerance of treatment, decreased effectiveness of treatment, reduced quality of life, and even reduced survival. This was a paper published in JCO where they looked at patients with metastatic colorectal cancer who were getting chemotherapy, and they compared the patients who had lost the most muscle mass in the first 3 months to those who had lost less muscle mass. And as you can see in that blue line, the patients that lose muscle mass, even in just those first 3 months after starting chemo, have a much shorter survival. So trying to improve that with interventions and pull that line up is something that is really important. In terms of toxicity, they've done a lot of studies now too, looking at different types of chemo agents, and specifically looking at sarcopenia, so low muscle mass, and risk of toxicity. And as you can see, you know, some of the top 3 chemos that are used are chemos that are used in GI cancers. And, you know, on the right, you'll see kind of the increase in toxicity in one cohort. I mean, patients who had sarcopenia had a 13.5% increase in grade 3 or 4 toxicity. So, I mean, patients who are malnourished are really at high risk, and identifying this early and trying to intervene is really key. So I became interested in this topic during my fellowship, and specifically I wanted to look at patients who are starting clinical trials to see if, especially the phase 1 clinical trials, which are designed to determine safety and preliminary efficacy, to see if nutritional status impacts outcomes on those studies. And the reason I thought it was important is because, as you'll see in that figure at the bottom, only 5% of oncology drugs that are tested in the phase 1 setting actually end up getting approved. So 95% don't. And my suspicion was that maybe some of the patients who are on these early phase trials might be malnourished and have sarcopenia, and therefore might not fare well in that study, and that could have implications in terms of how the drug is moved forward. So I accrued 100 patients to this study, and these were all patients who were starting phase 1, primarily clinical trials at Fox Chase, and most of the trials were actually immunotherapy-based trials. And I did the PGSGA, so one of the validated nutritional assessments, and I found that almost 40% of the patients enrolled on these studies were critically malnourished. And these patients have to have a normal performance status in order to get on these studies. So you can see that even if you have a normal performance status, doesn't mean that you're well nourished. And GI cancer patients especially had high rates of malnutrition. I also found that 50% of the patients were sedentary, so kind of goes somewhat along with nutritional status. So really high rates of malnutrition in this population. What I ultimately found is that patients who were malnourished or had a PGSGA score greater than or equal to 9 had significantly increased risks of grade 3 toxicity, so 69% versus 36%, and then significantly increased risks of hospitalization, 62% versus 28%, and also lower response rates to the drug. So nutritional status led to very poor outcomes in this population, not as strong for physical activity. And then if you look at survival, patients who were malnourished had a average survival of a 6-month survival of only 47% versus 84% for patients who are not malnourished. So I mean, malnutrition could just be a signal that the patients have more aggressive tumors and other things and weren't going to fare well anyways. But I think this is really key preliminary data, finding these striking differences between patients who are malnourished and non-malnourished. We also did look at psoas muscle area, and we also found that patients who had a low psoas muscle area were also at higher risk for grade 3 toxicity. And then psoas area actually was a stronger predictor of toxicity than even the nutritional score. So that could be something to potentially look at down the road. I have done some preliminary data in patients with GI cancers using Bioscreen as well. So this was a pilot study where we did Bioscreen, the FFQ, in 23 patients with metastatic GI cancers. And the score was actually pretty similar to the score in the colorectal cancer survivor population, 65. And then we did do a 3-month assessment in some of the patients. And we found some changes in terms of, some improvements in, fruit, green bean, but decreases in whole grains and plant protein and seafood protein. So, I think in the future, potentially using a computerized FFQ in conjunction with the other standard nutritional measures could help highlight certain areas of weakness and help us, guide patients from a nutritional perspective better. So that leads me to my last couple slides where I'm going to just touch on our recently funded MANNA grant. So this study is a medically tailored meal program to improve diet quality in colorectal cancer survivors. Kara and I are doing the study together along with support from other members at Fox Chase. And basically, the study is designed as a feasibility acceptability study where we're going to look at a cohort of early stage colorectal cancer patients undergoing adjuvant chemotherapies with 5FU based chemo, and then also look at another cohort of patients with metastatic colorectal cancer, also getting 5FU based chemo, and then we're going to do a 3-month intervention, and that 3-month intervention is incorporating diet counseling, which is going to be performed by the MANNA dietitians. The MANNA is medically tailored meal delivery program, and then we're also going to try and integrate the computerized food frequency questionnaire to see if we can utilize that data to also maintain or potentially even improve diet quality while we're addressing overall nutritional status. So as I said, the primary endpoint is feasibility and acceptability, and then we're also going to look at changes in nutritional status, muscle mass, diet patterns, and quality of life, and also try and get a sense of are these patients having challenges with chemotherapy in terms of toxicity or risks of hospitalization? To accomplish those endpoints, we're doing a variety of measures at both baseline and 3 months. And just to conclude, so as I kind of mentioned, obesity and lifestyle factors are strong risk factors for GI cancers and can lead to a worsened prognosis. However, after being diagnosed with the GI cancers, issues with malnutrition and cancer cachexia dominate the discussion, and those can increase risks of poor outcomes. I do think the early phase trial population also warrants some attention, and we've thought about designing some studies there too. But ultimately, I do think personalized approaches are key, and I think integrating our dietitians potentially with the help of the bioscreen feedback and kind of standardized screening could really help us identify these conditions early and improve outcomes. So with that, I will stop sharing and I'll hand it back over to Julianne.
Thank you so much, Dr. Jain and Kara. That was a wonderful presentation. So we've asked people to put any questions that you have in the question and answer box. So while I'm waiting for some questions to come up, I had a question that came to mind. So a lot of the studies so I found it interesting, Kara, that when you presented the efficacy of counseling by registered dietitians versus some of the other modes of nutrition care that we think of in cancer patients. And I was wondering, a lot of the studies that are done on cancer patients after they're discharged or maybe after treatment have to do with looking at nutritional supplements and outcomes. So do either of you, Dr. Jain or Kara, know of studies that show how do we do when we recommend food? So when we recommend individualized eating recommendations or food, healthy dietary patterns, do people come out of malnutrition in similar ways to some of the studies that show how that supplements help? Or do we have any studies like that?
It's a great question. So when you say supplements, are you referring to like oral nutrition supplements,
Yes.
like Boost or Ensure,
Yeah.
some of the nutrition dense products that we use? So I cannot reference any studies right now that say utilizing this specific product could help sort of lift a patient out of sort of their malnourished status. But we know that they do help really to make every sip, every bite count. And we use them regularly at Fox Chase, and it is my understanding that they're used regularly across clinical medicine across the country because we're really able to pack the most protein and the most energy into these little boxes. Although I will have to say, if anyone has ever done a real taste test with some of these products, it's one of the things that I've done with my team so that they sort of know what they're recommending to patients. Some of them are not the most appealing. And then there are others that I think, both clinicians and patients really enjoy. So that would be something to take into consideration. I will say though, that when I was referencing sort of sending somebody to the registered dietitian for medical nutrition therapy, that does include the individualized plan, the healthy diet recommendations based on that individual patient. And there is literature to support that. If that answers your question.
Great, thank you. And this next one is for Dr. Jain. Do you have any thoughts on checking metabolites or microbiome of cancer patients pre and post nutrition intervention that result in diet improvements, I guess improvements overall?
Yeah, I definitely think the future is kind of finding certain biomarkers that can assess people's responsiveness to different diets and different diet patterns, and kind of personalizing our approaches even more. When I was at Ohio State, before I came back to Fox Chase, there was a big metabolomics core, and there was a ton of researchers trying to look at various metabolomic technology to look at metabolites. And similarly, the microbiome field is kind of exploding. I think the areas where I've seen those things most incorporated are kind of, especially like the immunotherapy microbiome interactions, but there's definitely, you know, a lot of data being done in those areas, but I personally have not done any of that.
Well, thank you very much. We're at 1 o'clock now. We so appreciate the time you both took today to educate us in this area. And we'll look forward to seeing your work again in the future. So thanks to everybody today. And we'll be sending out a recording after the session. Okay. Thank you again.
Thank you.
Bye-bye.